Mr. Bagnall, I think you must be finished your round. Your time was almost up. And we have amended the order rotation to eliminate round 5. So the last two Conservative and Liberal 5-minute spot will be eliminated from this particular meeting. And we will have Mr. MP Brunet-Duceppe and Mr. Garrison both having their 6 minutes to complete the first round with this particular panel. We will take a short, quick break to bring in the new panel, and then we will recommence with questioning rounds 2 through 4. Okay? So, all right, Mr. MP Brunet-Duceppe, if you are ready, you have the floor.
Merci beaucoup.
Thank you very much, Madam Chair. I would like to thank the witnesses. Oops, I can hear myself in my ears. All right. I would like to thank the witnesses for their participation. Ms. Fines, your presentation really touched me hard, and I'd like to thank both of our witnesses for being with us today. Ms. Fines, I have a very simple question for you. It's important for parliamentarians to hear your answer if you are able to provide one. In your view, what were the biggest obstacles that you and your family faced when seeking mental health services from the Canadian Armed Forces?
I think for Stuart, he had multiple hospitalizations. He had multiple suicide attempts. For him, the obstacle was he did have a short stint at Edgewood and Nanaimo, which was not an appropriate place for him. And I think for him, that was a huge obstacle, was being sent to somewhere where military members speak to other military members and kind of have an idea of what's going on. That's why he wanted to be sent to Homewood, and they refused to do it. In terms of the family here, once we realized that Stuart was in trouble and not doing...
Quand on s'est rendu compte que Stuart avait des difficultés, qu'il avait du mal, eh bien...
have conversation with the base, with the chaplain, and I did speak with the doctors at the civilian hospitals. The attitude I got from the hospitals was, he's a big boy, let him get on with it. And the attitude I got from the base was, he's a big boy, get on with it, let him get on with it. He's going to do what he's going to do. Neither of which were very satisfactory to me as his mum. And I pushed hard. And after Stuart died, like I said, there was a real closing of the ranks, because I think they knew that there were some mistakes that, just like I said, had a catastrophic effect. If I may, there's one thing that I really, really hope that everybody hears today, is that mental health issues amongst our soldiers are workplace injuries. They're not defects. They're not genetically, predisposed to killing themselves. They don't want to die. I have yet to meet a soldier who wants to die. They want to get back to doing what they have done best. And that puts an onus on all of us in each of our capacities to ensure that happens. Thank you.
Merci beaucoup, Madame Fines.
Thank you very much, Mrs. Fines. I have another question, and it's for Ms. Carley. Did you feel there was any difference in the services offered because of the pandemic? Did you notice that there were any differences in the services offered by the military or the armed forces? Did you see any positive or negative differences?
Thank you very much. The challenges I think that we experienced during this pandemic around access to mental health supports really relates to the pivot that organizations were able to make to serve people on a virtual platform. From our perspective, we were able to make that move very, very quickly because we are an independent organization. But what we have seen is that the Canadian Armed Forces had a lot of restrictions around connectivity on a virtual platform. And so early on in the pandemic, there was some huge challenges in terms of members accessing mental health supports. I would say that that situation improved over the course of the pandemic. I think that one of the major trends that we have seen and we continue to experience is an increase in interpersonal violence in the home, relating obviously to just the situation of isolation and the extra stress and pressure that could be financial and certainly has been emotional and psychological during this pandemic. The Canadian Armed Forces has responded to that in terms of increased resources around interpersonal violence, and we are finding that our caseloads have become quite heavy. And so this is something that we do experience all the time, but we've certainly experienced a spike in this during the pandemic. Thank you.
Merci infiniment à vous deux.
Thank you very much to both of you. I think that my time is up. The committee members really appreciate your participation. Thank you very much. Mr. Brunel-Duceppe.
Please.
Thank you very much, Madam Chair, and thank you to Ms. Fines. It's hard for me to call you Ms. Fines because we've worked together so many years now, and out of this tragedy, one of the things I've gained is the privilege of knowing you, your husband Sean, and your second son, and the incredible courage you continue to show. I have heard recently from other families who just don't feel strong enough to come forward and do what you're doing. And so I know that they all thank you for being here. Time is limited, so I want to go back to the question of taking self-harm out of the military code of conduct. We've stressed that that's symbolic, but I'd just like you to comment a bit more on what you think that would help with by taking this section out. Most of our NATO allies don't have such a section in their military code of conduct. And so it's hard for me to see why we maintain it. But Ms. Fines, can you tell us what you think would happen as a result of removing this?
Well, first of all, I don't see a downside in removing it, and I definitely see an upside to that happening. A good soldier, a well-trained soldier, learns very, very early on what the rules are, what's expected of them. This rule doesn't have to be enforced for it to have an effect. They know that it's kind of dangerous to them, right? There's always this little thing lingering in the background, and I think they kind of, when they're not well, they don't need one more thing of, oh my goodness, would they really do that to me? Would they lock me up? I think that the NDA is a fairly succinct act. And I think every soldier is well schooled in discipline. And I would respectfully suggest that if there's just one more thing that maybe might make a difference, then what's the downside? Like, just get rid of it. As I said before, I was personally astounded when I found out about this. I'm sure Stuart would have known about it. So yeah, like if it disappeared, it would just be a really, really good thing.
Thank you very much. I want to turn to Ms. Carley, and first of all, I do hope you get an apology over the toing and froing over your appearing as a witness. I was assured last night personally by the Minister of Defense that there was no intention to try and prevent you from appearing today. So I hope that apology does come. So I know that the Military Family Resource Centre is play an important role, but I think that's not always recognized. So that's why I thought it was important for you to be here today. When it comes to us still losing one serving member a month on the average across the country to suicide, and when it comes to figures that suggest as 10 times as many attempt suicide, I wonder if you could just tell us a bit how that affects your operations as a military family resource center.
Certainly. Yes. No, thank you. I really appreciate the opportunity to be here. I think that what the testimony is telling us today is how important the voice of family is and how compelling it is to create a culture shift so that families can have a voice when these occurrences happen. As recently as 2 weeks ago, we experienced the suicide of a military member at CFB Esquimalt. And the way that it affects our services is that we rally to support that family. And we often find that it takes on an advocacy role. For example, this member was part of a very small unit, and the other members in the unit were devastated by the loss and also by a feeling that somehow they missed something. But I can tell you that the comment this morning from our witness, upon hearing the news, saying, yes, I know this, I knew this was going to happen. We hear this very, very frequently in these cases of completed suicide and attempted suicide, where family members are working really, really hard to get that military member to the care that they need. And so our involvement as a military family resource center is literally to walk alongside of that family and to help them in terms of their inroads so that they can have a voice, so that the military can become more trauma informed. And what I do see with our military members is that they struggle so much with this kind of loss. And so our work along with the base mental health team to support the colleagues of these members, and I'm sure colleagues of Stuart would have appreciated some support, because there's quite a legacy that lingers. I think that there is probably a very aggressive approach to operational security, and sometimes information isn't forthcoming that should be forthcoming. So we're really talking about a shift in culture here. Thank you.
And I know we have very little time. Can I just ask you quickly, do you see delays and barriers to serving members getting the mental health assistance they need, and does that affect their families?
And yes, we do. And in the recent suicide, this member had been attempting to get the right kind of care for 2 years. As our witnesses told us this morning, oftentimes the referrals are not relevant in terms of where our members are going. I think this has to do with a system that feels overloaded and overwhelmed. And I do also reiterate my previous point that it concerns me that there are no mental health supports after hours and on the weekends, which is when oftentimes a crisis will hit.
All right.
I know I'm out of time. Can I just say thank you once again to both of you for your very important testimony today.
Thank you. Nice to see you.
And I would actually like to reiterate our thanks, our recognition of the work that you do, both of you do, to actually support members of the military and their families. I think your testimony here today was absolutely pivotal and crucial to this undertaking, and I just wanted to say thank you. And with that, we will end this panel, take a 1-minute break, and start again with the second panel. welcome our two witnesses for the second panel. Dr. Elizabeth Rowland Harris, Senior Epidemiologist and now Director of Force Health Protection at the Health Agency of Canada. She authored the 2019 report on suicide mortality in the Canadian Armed Forces, as well as an article titled More Than Just Counting Death, The Evolution of Suicide Surveillance in the Canadian Armed Forces, and then followed by Dr. Jitendra Sareen, Head of the Department of Psychiatry, the University of Manitoba, and a member of the 2016 Suicide Expert Panel, and he was the chair. So with that, I'd like to welcome Dr. Elizabeth Rowland Harris for your opening remarks, please.
Thank you, Madam Chair. Can everyone hear me? Great. So my name is, as you were just told, Dr. Elizabeth Rowland Harris. I am an epidemiologist by training. I hold a Master's of Science in Epidemiology from the University of Toronto, as well as a PhD in Infectious Disease Epidemiology from the London School of Hygiene and Tropical Medicine in the UK. So from June 2006 to September 2019, I worked as a senior epidemiologist for the Directorate of Force Health Protection within the Department of National Defense. And during my tenure there, I was responsible for the military suicide epidemiological surveillance file, and as well as being the project lead and co-primary investigator for the Canadian Forces Cancer and Mortality Study 2. This study was conducted in collaboration with Veterans Affairs Canada and Statistics Canada, and it endeavored to describe the types and the numbers of deaths in both still serving and released military personnel. And these deaths included suicide deaths. En septembre 2019, j'ai quitté le ministère de la Défense et
In September 2019, I joined the Public Health Agency of Canada. Today, my appearance will be based only on what I did when I was at National Defense. I'm not here as a representative of Public Health Agency of Canada, nor does it have anything to do with what I do right now at the agency. I thank you very much for the invitation to appear.
Dr. Jitendra Sareen, please.
Hello, can everyone hear me?
Yes.
Hi, it's a real honor and a pleasure to be here today, and it was really heartfelt to hear the testimonies of the previous speakers. Thank you to everyone. It's a pleasure. So I've been asked I'd like to also acknowledge that I'm a psychiatrist at the University of Manitoba, department head, and I have worked at the Veterans Affairs Operational Stress Injuries Clinic in Winnipeg as a consulting psychiatrist since 2009. The research that I'm presenting today is funded by the Canadian Institutes of Health Research, as well as the Canadian Institute of Military Veterans Health Research and True Patriot Love. And the focus of the presentation will be on the 2016 report of the Mental Health Expert Panel on Suicide Prevention to the Canadian Armed Forces. I co-chaired this panel with Dr. Rakesh Jetley, as well as a number of suicide experts from nationally and internationally, as well as DND policymakers and VAC representatives as well. The key observations of the mental health panel in 2016, which met for 2.5 days, was that there are approximately 11 suicide deaths per year in the Canadian Armed Forces. The 2013 Canadian Armed Forces survey that was conducted by Stats Canada showed that the past year suicidal ideation rate among active military personnel was 4.3%, and suicide attempts occurred at 0.4%. The panel recognized that suicide is a behavior that is extremely difficult to predict at an individual level. Although the goal is to have no individuals die by suicide, the expert panel recognized that at times not all suicides can be prevented. The risk factors for suicidal behavior among military and veterans We looked at all of the literature internationally as well as specifically in Canada, and a number of the risk factors that are well known include being male, having relationship difficulties, or being unmarried, depression, post-traumatic stress disorder, and substance use disorders like alcohol use can often combine to lead to an increase in risk of suicidal behavior. More recently, there's been an understanding that traumatic brain injury, as well as chronic pain conditions and new onset of physical health conditions, can also increase the risk of suicidal behavior. We also know that adverse childhood experiences have been strongly linked to suicidal behavior, not only in military personnel, but also in civilian populations. Our work and others internationally has shown that exposure to traumatic events during deployment are associated with suicidal behavior, witnessing atrocities, combat exposure, seeing a fellow member die in combat can increase the risk. But deployment itself is not a risk factor for suicide. A history of self-harm behavior, as well as transitioning to civilian life, are seen to be very important vulnerable periods. And one of the other important areas that's been discussed by previous witnesses is that important time of crisis when people are either admitted to the hospital or an emergency setting. That period before and after can be a really high vulnerability period. So the report that was completed and submitted had 11 specific recommendations for the Canadian Armed Forces. The first recommendation was to have a new position called a Suicide Prevention Quality Improvement Coordinator. And this was based on a strong understanding that suicide prevention requires a coordinated effort between the health system and the social system, and that similar coordinators have been implemented in the U.S. Veterans Affairs. There has been an increase in awareness of mental and improvement in access to mental health services, but as previous members have witnesses have said, there still is a stigma in receiving care. The Suicide Prevention Coordinator would develop a patient and a family advisory committee, review characteristics of suicide in the military members, determine the needs for education among staff for suicide-specific interventions. And there are, and I'll talk about those, there are a number of them that have evolved more recently. And then determining the need for education in primary care and specialty services, and what are the gaps that can be improved. Recommendation 2 was to take a systematic review of all CAF member suicides since 2010. The medical professional technical suicide review occurs for every individual suicide death, but it would be very, very important to look at all the deaths consecutively to see where did the suicide occur, what were the pattern of recent work in psychosocial stressors, what types of physical health problems were prevalent at that time, what proportion of individuals were actually getting evidence-based suicide treatments, and among firearm-related suicides, what measures were taken to limit access prior to death. This type of review could help us guide policy and to target suicide prevention in an evidence-based model. There is, as I mentioned before, there is this pivot in the field of suicide prevention. Previously, the idea of suicide prevention was to treat the underlying depression, alcohol, and substance use problem. But now the field is really shifting that we need to treat both the depression and underlying condition, but also target intervention specifically for suicide. And so some of the examples are suicide risk assessment. There is a program called the Suicide Assessment and Follow-up Engagement. So if a veteran in the US has an emergency visit due to a crisis, there is brief intervention and safety planning afterwards around means restrictions, coping skills and social supports and outreach after that program. We recommended that it would be helpful for the Canadian Armed Forces to review some of those novel programs that are being implemented in the U.S.
All right. Thank you very much, Dr. Serena. I appreciate that. I just want to make sure we have a little bit of time left for questions. So
Sure.
Thank you very much. And we did receive a presentation from Dr. Serene. It is being translated, and we will forward it once we have the translation. So with that, we'll hand it over to Mr. Dowdall for your questions, please.
Thank you very much, Madam Chair. And I too want to thank the witnesses today for their testimony. It's been compelling for sure, heartfelt, and I think everyone's looking for some answers as we move forward. I'm certainly proud of our armed forces. Whenever they've been needed, they've been there. And I think it's our time and our duty to make sure that we take care of them now, as well as the ones that are post-military. So very happy to see when the Joint Suicide Prevention Strategy came out in 2017. And according to National Defense, there were 15 suicides among armed force members in 2018. And this number increased to 20 in 2019. I've asked and do not have yet the number that we have for 2020. So my question is, how effective has this strategy been, and how is its effectiveness being measured?
So, my role with the panel was to really chair the committee and make the recommendations, and so I have not been following the specific changes that have occurred, but maybe Dr. Harris may want to add.
I have limited insight on this, having not been a part of the organization in over a year. And things may have evolved. What I can say is that while I think that the annual suicide report from D&D is very important, I think that by virtue of the way our governance of the military and veterans is set up, we have a tendency to look at problems in silos. So we look at suicide in the military, and then we look separately at suicide in the veterans population. And really, it's a continuum. We talk about it as, as a life course approach where it's not a question of whose responsibility it is. It's an individual that goes through, different stages in their life. And so I think that if we're thinking, I can't answer your specific question, but if we're looking at improving things more broadly, I think that there has to be a look at, changing the way things are done and dividing or looking at still serving and released personnel as two discrete populations, when really they are the one and the same population with the same challenges and the same experiences, and they're just at a different point in their life course. Thanks.
So I think those are great comments, and I think that sort of speaks to the earlier witnesses as well, that this is a 24/7 issue that we need to address, and perhaps I know here working with the local hospitals that they've thought of different ways that they could probably set this up and not be in a silo. But one of the things I've been really proud of the last little while, I don't know if you've followed, just a quick comment from each of the witnesses, is that the MP, my colleague from Caribou, Prince George, has brought forward an idea to have a suicide prevention line that would be simple to remember, which is 988. And we were hoping to probably have this implemented before Christmas, as you know, which is a tough time of year for many individuals in the military as well as civilians. So just your comment on what you think, or if you think that's a good idea to really bring it all together and make sure that we're there for everyone 24/7.
Yeah, I think that absolutely, that's having the suicide lines are extremely important, and as the previous witnesses have said, that during we need that availability during a 24-hour period. And crisis often occurs, and families are often left trying to support their member. I think the important part is what happens after the crisis line, and I think that's where we really want to make sure that the person gets into the right pathway and right care, and they're not waiting on different waiting lists and that happens not only for military members, but many people in our system. And I think that the pandemic has really pivoted us into virtual care, and we can do a lot more things virtually now that reduces some of the stigma for people having to walk into a building for an outpatient appointment. So we do need to take the opportunity with the pandemic to really improve our access for our patients and families in getting care at the right time, because it is a 24-hour issue.
All right, thank you very much. Monsieur Robillard, s'il vous plaît.
Oui, bonjour.
Yes, good afternoon. Can you hear me properly? Can you all hear me properly? Before I get going, I'd just like to make sure everyone can hear me. Good. My question is for Mr. Serene. A suicide among the Canadian forces is a death for all troops. Could you perhaps identify the shortcomings of the current system that is in place at the Canadian Armed Forces? This is the interpreter. Can you hear the English interpretation? Mr. Serene, are you able to hear the English interpreter? Mr. Serene?
Of your screen, you'll see a globe with interpretation. Just go and select English.
On Zoom?
Yes, in the main Zoom screen where you have the pictures of everybody. At the bottom, in the middle, if you bring your mouse, you'll see participants, and right to the right of it, interpretation.
Oh, okay.
Can I resume?
Okay.
Ça sera pas
Now
très
it's
long, Monsieur Robillard.
well, I have it on English, so I didn't hear any.
Okay.
Mr. Serene, can you hear the English interpretation now? Can you hear? Mr. Serene, could you please say yes? If you can hear? Good. Yes. Go ahead, Mr. Robillard. A suicide among the members of the armed forces is one too many. Could you tell us about the shortcomings in the system to offer mental health services at the current time at the Canadian Armed Forces?
So I think, the recommendations that we made in 2017 really encouraged trying to be very specific around suicide specific intervention. So there has been a lot of effort in improving access to treatment for depression, post-traumatic stress disorder, but there are specific suicide prevention strategies, psychological therapies, as well as in the moment of crisis, there are specific things that can be done. And our recommendation was to review and look at what the needs are and see if we can have more training in those suicide-specific strategies that are in collaboration with other medications, supports, family supports, but ensuring that our members that have made a suicide attempt or have had thoughts about suicide are really getting that specific suicide-specific therapies and medications. So that's the report that we made in 2017. I'm not clear what level of change that's occurred in the military.
Quel est le soutien apporté aux familles?
What is the support given to the families of members of the Canadian Armed Forces who die through suicide and those who who attempted suicide?
I think that was also another recommendation that we should look at those specific processes and policies. But I'm not sure exactly what is specifically being done in the military today when somebody has lost a family member to suicide. It's a very important question.
Au vu de votre expérience personnelle.
In your personal professional experience, what measures that are currently in place could have prevented a suicide within the armed forces?
Well, the most common things that have been shown to be helpful in reducing suicides include restriction of access to means, which include firearms or large quantities of medications. Making sure that we're recognizing depression and post-traumatic stress disorder and treating that with appropriate treatments, as well as engaging family members and supports in any sort of crisis planning that occurs when somebody is suicidal.
All right, thank you very much. Merci beaucoup. Monsieur Brunel-Duceppe, s'il vous plaît.
Merci, Madame la
Thank you, Madam Chair. I would like to thank the witnesses for appearing before us today to discuss this extremely important topic. I would also like to thank the members of the House of Commons who are doing their utmost under the current circumstances. Hats off. In the 2019 report on suicide in the forces, we don't have the suicide rate among women because it says that there aren't very many of them. And in 2017, 2018, I don't think any woman committed suicide. I was wondering how you could explain that difference between the problems of mental health that women experience versus men who are members of the armed forces. Either witness can answer that question. It's a fairly clinical question, so I think it would be up to my colleague to answer that first.
So that is the, men are much more likely to die by suicide than women in the general population, and we know that men experience more alcohol use as well as depression. Women in the military have a higher likelihood of having post-traumatic stress disorder and anxiety disorders, but lower likelihood of having alcohol and drug use. So that's some of the work that we've done. I think it's likely because of the low number of so I don't have a good answer to why we have such low rates of suicide in active military. But when we look at veterans, there is an increase in suicides among women veterans at that period of transition. And as Dr. Roland Harris is saying, it's really looking at that transition from military to veterans life is an extremely important time.
Yes, indeed. As my colleague said, especially when it comes to women, it's very important to take a broader perspective. If you look at the military, you can see an increased level or rate of suicide among women, especially if you look at the 40-year age category. Perhaps I'm wrong with this age group, but it often coincides with the time when people are moving from the military system to civilian society. And it's also a time in a family's life where you see an increase in marriage breakdowns. It's often the age where children became teenagers, and so problems developed. So a woman's role within the nuclear family changes and causes stress. So that is why we are looking at women, not just at what is happening during the years that they are in the military, but also the years afterwards. Thank you very much. The floor is now for Mr. Harrison.
Thank you very much, Madam Chair. We do, of course, focus on those who successfully die by suicide, as we should, as it's a big loss to the Canadian Forces and their families. But I wonder if either of the witnesses would like to comment on the fact that perhaps this is an undercount of the problem, since the problem is the attempt to die by suicide. And we know that some 20 to 25% of medical releases from the military are for mental health reasons. And we know that from US estimates that as many as 10 times attempt to die by suicide is who actually succeed. So are we, by focusing on that number alone, are we undercounting the problem?
It's a numbers one. Are you okay if I take it, Jatinder? And then you can.
Yeah.
Okay. So yes, in a nutshell, yes. Obviously, it is just we call it the iceberg. It's the tip of the iceberg. There's obviously a lot of stuff that's happening, underneath the water. In terms of just from an accounting perspective, taking away, the emotional or the humanistic side of things. The reality of it is, it's very hard to count attempts. We only ever see the most severe ones on our radar because those are the ones that seek medical care because they require it to survive, in essence. So, even best efforts to try and capture that sort of underlying reality is very difficult by virtue of, the breadth of severity with respect to attempts. So.
I would agree with your comments that the suicide rates are likely underestimates. Accidental deaths some of them could also be suicides, but so that's also important. And then suicide attempts are also, as Dr. Roland Harris has said, are difficult to capture. So you're absolutely correct.
Did the expert panel, Dr. Serene, did the expert panel look at the interface between stigma and military discipline and the attempts to prevent suicide? Because we heard very powerful testimony from previous witnesses that it's the stigma and the discipline that's often applied to those suffering from mental illness that contribute to the difficulties in getting help.
That was not a topic of specifically discussed in the 2.5-day panel. Clearly, barriers to care, fear of the impact of getting care on the person's career was absolutely seen to be an important factor of why people may not come forward with care.
All right, thank you very much. Madame Galland, please.
And through you to actually go to Dr. Sarin first. You had chaired the 2016 expert panel report and made a number of recommendations. Which of the 11, if any, are outstanding, have not been acted upon?
Thank you. So I have not been keeping track of all the different recommendations, but some of them have been implemented, but it would be best to ask the Canadian Armed Forces. They were accepted. The report was accepted, but for actually getting the information of what was implemented and what was not, it would be best to ask the DND.
Okay, and well, actually, recommendation number 9 was to consider novel methods for delivery of psychological and pharmacological interventions. Would you say that the CARIN, the computer-assisted multimodal memory desensitization and reconsolidation, would be one of that, as well as the EMDR therapy?
Yes, I mean, I think our focus of that particular recommendation was really to ensure that moving away from the one-to-one office visit to using more virtual means, so telephone-based therapies, video conferencing based, because people often have difficulty accessing services because so any type of therapy can be usually done virtually, and now with the pandemic we're seeing that. Our aim of that recommendation was to really try to have more outreach and look at novel ways of delivering care rather than the usual office visit one-to-one.
All right, so you're talking about virtual therapy now as well. I take it with the onset of the virus. For Elizabeth Rowland Harris, since what year did statistical data on CAF personnel suicides begin?
I don't recall off the top of my head, but I believe it is in the report. It is, I believe, sometime in the 1980s. So this has been going on for a fairly 1995. Sorry, it's in the title of the report. So since 1995.
So the statistics have been kept since 1995, yet over the years, at least 20 years, there has been an outright denial of statistics being kept until very recently. So would you actually produce the documentation substantiating these statistics so that we can go back and see how we're comparing now as opposed to then?
So I was at D&D from 2006 onwards, and I can't speak to prior to 2006, but I can tell you that that those statistics were being tabulated, analyzed, and published since 2006 at the very least, and the reports were at the time being published on the National Defense.
And what about stats on PTSD? I recall early in the 2000s, Colonel Stephen Grenier was the trailblazer trying to have the public as well as the military understand that PTSD was an operational stress injury, not just an excuse or to get out of doing your duties. So what about the stats on PTSD?
So that was if it was being collated, and I can't speak to it, it was done by the Directorate of Mental Health. So suicide was kept under FHP for historical reasons, and the rest was done through the other directorate. So you'd have to have someone from that directorate.
So PTSD would be under a different protectorate.
It would be under Mental Health Directorate, yes.
Okay.
I would also like to add that I did submit a few specific articles for this committee to review that talk about the national trends in suicidal ideation and attempts from 2002 to 2013 in Canadian Armed Forces. And we've also followed a survey of Canadian Armed Forces veterans, 3,000 military members that have followed over 16 years. And we are starting to publish some of the key papers that will describe how common mental health difficulties are over time, and as well as some of the gaps in services.
Thank you, Madam Chair.
Thank you, Madame Gallant. Mr. Bazan, please.
Thank you, Madam Chair, and it's indeed a pleasure to be able to, first of all, thank our witnesses. And I know that Sheila Fines is still with us, and I just want to thank her for her advocacy, for telling her story, which is a difficult one to do. But again, it's because of your voice that we've been able to address a lot of these issues over the years. And, you know, I'm all too familiar with the loss of Stuart, as well as Shauna Rogers as parliamentary secretary when we dealt with those. And all too often we ran into roadblocks with you know, provost marshals and national defense blocking the release of information in a timely manner and treating families with respect. And I think that because of Sheila Fines' advocacy, a lot of that has changed now. And despite the incredible agony and the tragedy of every suicide that we experience, at least there is, I think, a better process in place now than there was, you know, 14 years ago. Or 12 years ago in Stuart's case. I want to ask questions to our witnesses about the clinical analysis of suicide. I know we always like to talk PTSD. I can tell you that 10 years ago, there was still a debate of if it even existed. You know, Ms. Glant just was talking about the trailblazing work of some lead psychiatrists on that. But we were still trying to put everything in a box. It was depression, it was anxiety, you know, it was other mental health issues. And have we ever been able to break down as to which of those issues, or do we lump them all together as PTSD, are the leading cause of suicide within the Canadian Armed Forces? And in particular, and I know I've had this conversation in the past with Colonel Urkash Jetley, is, how much is still the trigger is either from, attribution to service, or how many of the suicides are happening because of, relationship breakups, financial difficulties. Are those the triggers, or is the trigger actually service related?
Well, I think that is a very complex question. We know that if you look at
I'll just say, and the reason I'm asking a complex question is that if we're going to be putting in place the proper mechanisms and trying to identify what the triggers are so that we can get help to those that need it the most earliest, knowing that resources are always finite, and if we do go down the path of a 988 number, and Nick, you mentioned already Doctor, you've already said quite clearly that, again, if you can have the 988 call-in number, but then are the resources there in the community, at the provincial level, in the national defense to get there and help immediately? And that's something that we need to deal with. So, how do we identify which are the high-risk factors, what's the trigger, and how do we prevent it?
So depression, as well as often another mental health issue like PTSD and alcohol, those are the common things that really trigger the increase in risk for suicide. And then somebody that's made an attempt before, those would be kind of the most common and the most important risk factors. Life stressors, whether it's work related or home related, have all been shown, especially financial stress, to increase, trigger the risk as well. And then specifically in the military and veterans, it's really that transition to civilian life where really having that sense of identity. Who am I after leaving the military? How is that impacting my social life as well as my family? Often becomes a very important component. We know that specifically the deployment-related experiences that are traumatic have been shown to trigger PTSD as well as trigger depression, legal issues in the military. If somebody has had those, that can also trigger suicidal behavior. So it is the important thing is that the vast majority of people do not die by suicide when they have depression or anxiety, but it's usually a culmination of all those things together. And I think as you've mentioned, there is often the military member is if they require an admission to a hospital, they have to go into the provincial civilian hospital, and that transition out is often a high risk period for everyone that is admitted. So really the panel really recommended looking at those key time points during crisis where things have become increased, and then really looking at some of the means restriction kind of processes that have the strongest evidence, not having access to a firearm during the crisis or not having access to a number of different medications.
All right. Thank you very much for that. We are going a little bit over time. Monsieur Brunel-Duceppe and Mr. Garrison, you each have 2.5 minutes left if you wish them.
Well, yes, thank you. I'll try to be brief. In the 2019 report, it says that the death rate by suicide is higher among different command stations than other areas. I was wondering whether you could say anything about the higher rate among land forces than other areas of the military. So higher rates of suicide among the land forces. Well, I don't have that information. With the statistics that we have, we are not able to answer the question as to why the rates there are higher. Because as Dr. Serene said, suicide is very multifaceted. Many factors can contribute to it. It's not a very simple question to answer. Even though we can't explain the underlying reasons, and perhaps Dr. Serene can add to that, it's like a red light that says that this is a special group that we should do more for, to really follow them closely. So we can't necessarily identify the underlying factors, but perhaps just knowing that this is a higher risk group, perhaps more time and effort should be dedicated to them. It's not just a question of 1 + 1 = 2, if that's your answer. Is that correct? Yes. Mr. Serene, Dr. Serene, rather, do you have anything to add?
Harris has captured it.
Yeah. OK. Bon, ben, je vous remercie. C'était ma question.
All right. Thank you very much. That's all I had to say.
That brings us to the end of this meeting. Thank you to our witnesses for joining us today. You have made a significant contribution to this study, and I want to say thank you for taking your valuable time to spend with us today, and to the committee members. I thank you for your questions. I think it was a very valuable session that will well inform our work moving forward. And with that, meeting is adjourned.